I hope you can see my screen.
Yes, Doc.
Yes, sir. Yes, sir.
Okay, great. Okay. So this is a common condition that we tend to see. So it will be brief because I'm sure you have a lot of wolo or knowledge on this topic, and not just knowledge, you've seen it a lot in practical practical life or in clinical practice, so we should be good with this. We'll be talking about gastritis and then peptic ulcer disease, okay? And I mean, principles behind these two topics are quite similar. It's just that once you look at the definition, of course, with an itis behind gastritis, then it tells you that we are just talking about inflammation, okay, of the inner lining. And once you're talking about peptic ulcer disease or PUD, I mean, along the line, I'll be saying PUD means peptic ulcer disease. And once you're talking about that, then it just goes beyond inflammation to a break in the mucosa leading to an ulcer, okay? So we'll look at the definition, which we've just talked about. I mean, we just said something slightly about. We'll look at the usual culprits of gastritis and peptic ulcer disease, the pathophysiology, the clinical features, what complications do they present or can they lead to? How do we investigate a patient who has a gastritis or a PUD? And then what do we do in terms of management? Okay. As I always say, everything is simplified according to the subheading so that it will be easier for you to learn and practice once you see your patients. But it's always good to take other sources of literature when you are free and just go power, so that if you always know something extra in terms of research and all that, it's good. So when we talk about gastritis, which is the inner aspect of the stomach is inflamed, okay? We are saying gastritis may be either acute or chronic, okay? With acute, then we expect that it's just something that is for a short while because you've been exposed to some agent. It comes in, causes the inflammation, and if you are able to manage it properly, it just goes away, and then that's it. Chronic, as we know, means that you have it for a very long time. You've gone beyond 6 months. It's on and off. Inflammation comes, it goes, and all that. Okay, so that is what acute and chronic is. So you could have this inflammation affecting every part of the inner aspect of the stomach, or it could just affect a very small region of the stomach. Sometimes when you read books, you also come across the term gastropathy, and gastropathy is not the same as gastritis, okay? Once we say gastropathy, it's telling you that there's a damage, you know, with the stomach. However, there's no inflammation, okay? But then gastritis, as the name suggests, will tell you that there is an inflammation of the mucosa. So this slide, I put this slide here to just remind us of our physiology and maybe partly the anatomy of the stomach. So you can see the various parts of the stomach. There's a part that joins the esophagus up there, which is called the cardia. And up here, you have a sphincter, which is called the cardiac sphincter. Then there's this large part here called the greater curvature, and then the small part called the lesser curvature. Then you have from the cardia, the next big part is what we call the fundus. Okay, then there's the antrum, which is here at the lower aspect here. And then once you come in here to the tube that comes to join to the first part of the duodenum, that is called the pylorus, okay? And then there's a sphincter, which basically closes off the pylorus and releases food in bits into the first part of the duodenum, which is called the pyloric sphincter. Okay, so when you take a look at it, the stomach has what we call the parietal cells, which is responsible for producing H+, which leads to the production of hydrochloric acid, which of course we know that's what the stomach makes, and it helps in digestion. It kills bacteria and all that. And then there's also a cell we call the chief cells, which is responsible for making pepsinogen, which is converted to pepsin and is involved in protein digestion. Okay, so parietal cells, H+, chief cells, pepsinogen, protein digestion. Then you come and then you have what we call the intrinsic factor, which is produced in the stomach. This intrinsic factor is needed in the digestion and the absorption of vitamin B12 in the lower part of the intestines. Then you have G cells, which are responsible for producing gastrin. It's called gastrin cells or G cells. Gastrin is a hormone which, when produced, causes the production of HCl. Okay, so you have G cells over here, as you can see. And usually when you look at the anatomy, you realize that it is supplied by, stomach is supplied by, you can see the vagus nerve here and all that. So for you to be able to make hydrochloric acid and all that, you can see the vagus nerve coming and causes the production of the HCl and all that. So sometimes the patient is making too much HCl, you can come and then cut off the nerve. As we go on, we would know, and that's also surgical. So the stomach, we're saying the upper 2/3 of the stomach contains parietal cells and then chief cells, which make HCl and pepsinogen respectively. Then the antral mucosa has the G cells, which makes gastrin and also secretes bicarbonate and then mucus. And this mucus is very essential in protecting the inner lining of the stomach, because without the mucus, then it means the inner lining of the stomach, which is the mucosa, is easily exposed to all those inflicting agents or bad agents. So that the mucus sort of gives the inner lining some sort of protection. So it's very, very, very essential. Without the mucus, the stomach would sort of kill itself because it's making hydrochloric acid. So the mucus helps protect the inner lining of the stomach itself against the hydrochloric acid that the same stomach is making. So once you lack this mucus secreting cells, or you have issues with the mucus secreting cells, then direct effect on the mucosa of the stomach, which will lead to inflammation. So etiology. So what usually causes inflammation of the stomach? The commonest is a bacteria, which is called Helicobacter pylori or H. pylori, which we are all aware of. So in about 80% of cases, it's H. pylori. And this is looking at our environment. If you go to other environments where, excuse me to say, they are not so dirty or they hold sanitation in high esteem, H. pylori won't be their commonest cause of gastritis. They would rather be looking at something like drugs like NSAIDs and whatnot. But in our environment, hopefully things might change one day. But as it stands now, because of the dirt, H. pylori tends to be the commonest. So there are other organisms like Helicobacter pneumoniae, Mycobacterium, Treponema pallidum, Clostridium, Proteus. All these things are capable of causing inflammation of the stomach mucosa. Cytomegalovirus, which is CMV, can also cause inflammation of the stomach mucosa. Then you have Candida albicans and histoplasmosis. And usually this is common in the immunocompromised people with HIV, people with some malignancies which compromise their immune system. they can have fungal infections all the way from the mouth to the throat, right down to the stomach. Okay. And then when you go to Japan and those places where they like eating raw fish, there's a parasite. This is called anisakidoses. So usually when you like eating sushi, you can get this parasite into your system, which can cause inflammation of the gastric mucosa, leading to gastritis. Then, of course, as I said, in our Western countries where cleanliness is held in high esteem, you can have NSAIDs being the common cause because they tend to abuse that a lot, over-the-counter pain medication. Also, iron, colchicine, all this can cause that. Then alcohol is also one thing that can cause inflammation of the stomach. Stress, acute stress can cause inflammation of the stomach. Exposure to radiation, bowel reflux, and then any condition that causes you to have a poor blood supply to the mucosa of the stomach can also lead to gastritis. How does this come about? We are saying that the stomach is supposed to have defensive factors like the mucus producing cells and all that, so that the integrity of the mucosa would be protected. If this barrier is broken, then you are going to have challenges. Okay, so there's usually, once you have an imbalance between aggressive and defensive factors, then you are going to have an issue in maintaining the integrity of the GI mucosa. Okay, so we're saying the stomach has a mucosal barrier, which is composed of plasma membranes of mucosal cells and a mucus layer. So a breach in the mucus barrier, the mucosal barrier, would result in exposure of gastric mucosa to aggressive factors, which we've talked about. Okay. So once you have a breach, then that's the exposure. Okay. What are the features?
Hello,
How
sir.
would, yes, please.
So please, can you explain the iron aspects, in terms of it causing gastritis?
Yeah, so just like the way NSAIDs can impair, it has an effect on misoprostol and, all those things, the natural prostaglandins and all those things. Okay, iron is also able to impair such defenses. So in effect, it affects the mucus producing cells basically. And iron can be very, very, very toxic. Okay, it can cause a lot of irritations. So once you once you have, you take in excess iron, excess oral intake of iron, it's going straight to your stomach and it can cause a lot of irritation. And that's why we are always cautious when we are dealing with iron. Okay.
Okay. Thank you.
All right. You're welcome. So you remember the diagram I showed you with the abdomen and the 9 compartments. And you saw where the stomach was. It was lying in the epigastric region. So usually these patients would come with an epigastric discomfort, and then they would have nausea, and then they would have vomiting as well. Okay. And when you touch the epigastric, region, it tends to be a bit tender. Okay. So what happens when there's inflammation? Sometimes it can get so serious that you end up bleeding. So you have a patient coming to you and when they vomit, they see blood in there. Okay. Once they see blood in there, then it is telling you that there's some problem going on in the stomach. Sometimes if the bleed is massive, once you poop, the bleed can actually change the color of your stools and makes the stool dark. So in taking your history, it's always important that you ask, are you vomiting? You see blood in it, what we call hematemesis. Or when you go and then you use a washroom to poop, what's the color of your stool? Is it dark? Is it black? Okay, and that's what we call melena stools. Melena is dark tarry stools, like tar, it's very dark. It tells you they are bleeding all the way from high up. So before the blood gets down there, the blood becomes altered and it looks darker. Okay, and we always have to differentiate this from a patient who is taking iron, because when you are taking iron, it also changes your stool and makes it dark. So when a patient comes to you and tells you that, oh, doc, my stool is dark, you don't have to quickly jump and say you have melena stools, they are bleeding. No, you need to ask, are you taking any medications? Are you taking iron supplementation? You can change the color of your stool. And of course, because we don't regulate a lot of our herbal medication, you need to ask, because you can't be too certain if the patient is taking any herbal medication which is changing the color of the stool. Okay. So bleeding is one. The patient can perforate if the inflammation is that severe. They'll go through and then they perforate and then they can have peritonitis. And sometimes when you are dealing with a chronic inflammation, it leads to formation of scar, especially at the pyloric region, which we talked about. So you can develop some inflammation and then it leads to scar formation here. So once the food gets into your stomach, the food is unable to move through here and get into your intestines. We call this gastric outlet obstruction. The outlet of the stomach, okay, has become obstructed. So food will stay here and won't go through here. Your patients will come with vomiting, and usually when they vomit, this vomitus would contain the food that they've eaten, and the vomit would be non-bilous. Okay, it means that they won't contain any bowel, because basically the food hasn't gotten down there to your small intestines where bowel has been released and all that. Okay, so they'll come and they tell you they are vomiting, and usually because you tend to have some form of obstruction here, they vomit and they vomit a lot. It tends to be profuse vomiting. Okay. So gastric outlet obstruction. So three main complications: GI bleeding, or gastric bleeding, gastric perforation, and then gastric outlet obstruction because of scar or adhesion formation. How do we investigate our patients? Clearly, if a patient has a gastritis, you can palpate, and once the epigastric region is tender, it gives you an indication you can start your medication, okay? But it's always good to know what is happening there. It's not enough to touch the patient's epigastric region and say, you have gastritis, so go and take omeprazole. No. What if the patient is bleeding? You miss it. What if there's some gastric outlet obstruction forming? You miss it, okay? And how would you know what is causing this gastritis in the first place? How would you know if it's NSAID or if there's some H. pylori there? Because the management would vary. If there's H. pylori, we expect that you manage in a different way than if it's just NSAID. Okay, so you need to investigate. So you can do a full blood count, you can do a H. pylori stool antigen test, which will tell you if H. pylori is present or not. There's also H. pylori serum antigen test, but usually the stool antigen test is more sensitive. Okay, then the patient comes and there's ulcer, gastritis, you're not so sure if the patient is bleeding or not. You can take stool and do occult blood. Occult is something that you can't really see, right? So you're doing stool for occult blood, and if there's blood in the stool, it will show. Also, because H. pylori, this bacteria is able to break down it's able to break down what we call it breaks down urea to form carbon dioxide and then ammonium. We do something we call a carbon 13 or 14 urea breath test, which you can do for them, and then you can assess level of carbon dioxide and all that, because this carbon has been labeled with a radioactive substance. So there's a way they do the test and they check. But of course, now we don't want to subject patients to all these things, whilst you can just pass a scope with a camera attached to it. So you pass and you do an upper GI endoscopy. It visualizes the stomach. It tells you if there's an inflammation. If there's H. pylori there, the endoscopy will show you. If the patient is bleeding, the endoscopy will show you. And this is not only diagnostic, it can be therapeutic, because once you see that there's a bleed, you can apply something to stop the bleed there and there where you've done the endoscopy. So now we don't see this classic urea breath test and all that. You can go ahead and do H. pylori test for your patient and request for an endoscopy so that you can see exactly what is inside the stomach. You can go and you realize that, oh, there's something there. Because mind you, H. pylori, which in our environment is about 80% of the cause of gastritis, can lead to or can cause gastric cancer. So if you have H. pylori and it's causing chronic gastritis, the complication could be gastric cancer. So once you go in and you see any funny looking lesion, you just take a biopsy and then send it for histopathology. Okay, so investigation is very, very important. So the management is based on the cause of the gastritis. Okay, so if it's alcoholic gastritis, we'll tell you to stop taking alcohol. Even if it's gastritis caused by NSAID or whatnot, once the inside of the stomach is inflamed, alcohol won't help you. You need to stop. If you're using NSAIDs, you have to desist from using NSAIDs. Okay, and then we can put you on proton pump inhibitors like omeprazole, esomeprazole, and whatnot. We can also put you on H2 receptor blockers. This H2 receptor blockers and proton pump inhibitors are basically supposed to limit the once the mucous membrane has become compromised, you need to reduce the hydrochloric acid production because that would make the gastritis worse. Sometimes we put our patients on antacids, so magnesium, aluminum, hydroxide, we put our patients on that. Be mindful when you're putting your patient on that. If your antacid contains magnesium alone, your patient can come to you with diarrhea. If the antacid contains aluminum, the patient can come to you with constipation. Okay, so these are things that you should know as side effects of your medication. If you do your H. pylori stool antigen test or your endoscopy picks up any H. pylori, then you have to do what we call a triple therapy for our patients. Okay, so the triple therapy, we are combining a proton pump inhibitor like omeprazole or esomeprazole. Esomeprazole is also the brand name we usually find on the market is Nexium. We are combining it with clarithromycin and amoxicillin, okay, or metronidazole. Okay, for me, I usually do amoxicillin, clarithromycin, and then a proton pump inhibitor. Specifically, because I don't want any issues with resistance, I do amoxicillin clavulanic acid. So I do amoxiclav plus clarithromycin and then esomeprazole. I go for Nexium. Okay, I put my patient on that. Sometimes this can fail, and when it fails, you put your patient to do a quadruple therapy for your patients. The triple therapy, you can do that for about 7 to 10 days for your patient. And then you leave your patient on the proton pump inhibitor for about 4 to 6 weeks so that the ulcer can heal. So you can start with a triple therapy for about 7 to 10 days. Then afterwards, you stop your antibiotics and leave your patient on the PPI for about 4 to 6 weeks. Okay, so they can be doing esomeprazole or Nexium 20 milligrams BD or 40 milligrams daily for the next 4 to 6 weeks. Okay, then afterwards, you don't want to repeat the endoscopy and see the results of your therapy. As I said, if it fails, you can do a quadruple therapy where you are doing a proton pump inhibitor and a drug that contains bismuth. And bismuth is known to impair H. pylori. So you can add it to your treatment with flagyl and tetracycline. Okay. When you read on, there's something called sequential therapy. Sequential therapy. So go ahead and then look for that on the internet. Sequential therapy for H. pylori. That's also another way. If your triple therapy and your quadruple therapy doesn't work, you can do a sequential therapy, okay, for your patient. There are a lot of protocols or therapies. This is like the simplified ones, but once you read more, you see a lot of things. And usually it's good to change it, because when you do this and it doesn't work, you don't want to repeat it the next time. You want to do a quadruple or a sequential therapy for your patients. Okay. So let's just try and finish off. And basically, the idea is similar. We just talked about inflammation of the stomach, which is gastritis. Now we are going to look at not just inflammation, but a proper breach in the mucosa, which leads to an ulcer, okay, and which is secondary to acid production, and that is peptic ulcer disease. And the treatment and presentation and complications are all similar. So just more of a revision of what we just talked about. So usually you can have defects in the gastric or duodenal mucosa. And this defects won't just stay in the mucosa, it would extend through to the muscularis mucosa. So once you are going beyond the mucosa to the muscularis mucosa, then it means that there's a deep breach in the mucosa, and we say you have an ulcer and not just an inflammation, okay? So there are two main types. Once this breach happens in the stomach, we call it gastric ulcer. Once it happens in the duodenum, we call it duodenal ulcer. So peptic ulcer is a broad term, and under peptic ulcer, you have gastric ulcer and duodenal ulcer. So from now, don't get confused. So once someone says, I have peptic ulcer, it's either the person has a gastric ulcer or a duodenal ulcer. Some people can, however, have both gastric and duodenal ulcers. Research has shown that duodenal ulcers tend to be more common. Okay. So just as we talked about, there's a disruption in the physiologic balance in gastric acid secretion, and then the gastroduodenal mucosal defense, which we've talked about. So we are saying physiologically, these are the defense mechanisms we expect. There should be, the stomach or the duodenum should have epithelial cells that are making a lot of mucus, okay? And this mucus, then prostaglandin, all those things, they help, they produce the mucus, and then they protect the lining of the stomach and the duodenum, okay? There's also a gel layer which covers the superficial portion of the gastroduodenal mucosa. And then you remember we talked about bicarbonate secretion getting to that part where the stomach links to the duodenum. This bicarbonate is supposed to buffer the acid. Okay, so all these things are in place so that you don't have excess acid production. So there's a presence of prostaglandin E, which also improves bicarbonate production in the mucous layer. So this is the physiological defense system. So try and go through. Once you have an imbalance between acid production and then the function of the physiological defense system, then you are in trouble, basically. Then it leads to the production, it leads to you having a breach in the mucosa extending to the musculary mucosa, and you have a peptic ulcer disease. You can see that the etiology is basically the same: H. pylori, NSAIDs, alcohol, smoking, severe stress. Sometimes you can have a tumor which makes a lot of gastrin. And remember, we said gastrin is a hormone, which this hormone basically causes the body to make more, or the stomach to make more HCl. So if you have a gastrinoma or a tumor making excess gastrin, then it means it's going to cause you to make excess HCl, and this is going to lead to what? Gastritis, and eventually a breach in the mucosa, leading to peptic ulcer disease. Okay, and of course, genetics. Symptoms similar. So there's epigastric pain. The main difference here is that in gastric ulcer, this epigastric pain is usually worse when they have food in there. So when they eat, because the food is going to have a direct contact with the stomach, and in the presence of food, the stomach will make more hydrochloric acid. The pain is worse. Okay, and usually when they vomit, they are fine. However, in duodenal ulcer, it's rather the opposite. The pain is worse when they are hungry, so they tend to eat a lot. So you can have two patients standing in front of you, and they would say both patients have peptic ulcer. One is slim, one is fat. Using that, can you diagnose who has a duodenal ulcer and the one who has a gastric ulcer? Clearly, the one who is slim isn't eating much. because whenever he eats, there's pain and he vomits. So that is the patient with a gastric ulcer. And the one who is put on weight, he cannot, basically stay hungry. So whenever he's hungry, he keeps eating. So usually in the night, they eat. So they put on lots of weight, okay? And that is duodenal ulcer. So that's how you differentiate. So when a patient comes and says, oh, doc, I have pain in the epigastric region, or they point to the epigastric region, then you would have to ask, when does the pain come on? Okay, does the pain come on when you've just eating and you need to vomit? Or does the pain come on when you are hungry? Just asking this question can differentiate between a gastric ulcer and a duodenal ulcer. Okay. So they vomit sometimes, and as soon as they eat, they are satisfied and they can vomit blood as well. Okay. The signs, when you touch the epigastric region, is tender. If they are vomiting blood, then they will be pale. If they have a gastric outlet obstruction because of some sort of addition or a stricture that has formed in the pyloric region, they'll have what we call a Sakashian splash. Okay, splash is not spelled well, it's splash. And this Sakashian splash, usually when you shake, you know that feeling when you drink water and then you shake yourself, you can feel the water moving in your abdomen. Usually when you eat and we wait for some time, we expect that the food, the water, everything would have moved down. But if you have a gastric outlet obstruction, it won't move down. So when we shake you a bit, we hear a splash sound in your stomach. Okay, it's called Sakashian splash. Complications, they can bleed, they can perforate, and you can have a gastric outlet obstruction, as we've talked about. Investigation, similar. So full blood count, you want to do H. pylori, because basically the etiology is the same. Upper GI endoscopy is very essential. Okay, you want to see what is happening. If there's any funny lesion, you want to biopsy. If there's bleeding, you want to stop the bleeding. If there's a gastric outlet obstruction and you can relieve your obstruction with your endoscopy, you will do that as well. Okay. And then, of course, a chest x-ray comes in handy if you are suspecting a perforation. When the stomach perforates, okay, or when the bowel perforates, you do a chest x-ray and you don't do an abdominal x-ray. Okay, so don't make that mistake. When the stomach or an intestine perforates, you do a chest x-ray. An abdominal x-ray is done when you have an intestinal obstruction. However, when you have a perforation, you do a chest x-ray because you want to visualize something we call air under the diaphragm. Once you have a perforation, there's going to be air sitting under the diaphragm there. I'll try and show you an we close for the day. So bear with me. I'll just go onto the internet and then I would show you an x-ray of gas under the diaphragm.
Hello, sir.
Yes.
Hello. I want to ask a question.
Yes.
Please, how do you know that the treatment has failed?
How do you know the treatment has failed?
Yes, sir.
Okay, so you can do a repeat endoscopy to see whatever is there, or you can do a repeat H. pylori test, stool test. Usually that's the common thing that we tend to do. We do H. pylori stool test to see if we will find something there. Okay. Are we okay? And the other thing too is your symptoms. Patients would present with symptoms even after you've treated, and once they present with the symptoms, you can see that, okay, your treatment or whatever you did might not have worked properly. So it's just a repeat of your labs, okay, or your investigations.
Hello, sir.
Yes, Mabel, are you okay?
Yes, sir.
Okay, great.
Yes, sir, please, how long will you wait? How long will you wait before repeating the H. pylori test? Because I was thinking maybe the antibodies will still be inside for some time.
Yes. So that is the other catch there. So usually you are actually not in a rush. Once you've done your 4 to 6 week treatment with your proton pump inhibitors, it's good you wait for a while. Okay, sometimes some people say wait for about 3 to 6 months. So that is where your clinicals, I always say, your investigations is good, but your clinical skills have to be up. So you still will need to ask the patient to come for reviews. You need to buy some time. So within that time, if the patient is symptom-free, then you take it as your treatment has worked. If your patient is not, and your patient is complaining of worse symptoms that are not as compared to previously, you don't think it's improving, you think it's getting worse, then you can go ahead and do a repeat endoscopy to see exactly what is happening there. In as much as endoscopies are quite uncomfortable, you wouldn't really have that much option if your patient is telling you the symptom is getting worse. Okay. Are we okay? Hello? Can you hear me?
Sir. Yes.
Yeah.
Yes, sir, we can hear you.
Okay.
Yeah, my
Yes,
question
sir,
is,
we can hear you.
there are some people that, there are some people when they are traveling or when they are in a car, they tend to vomit after eating. Does it have any relationship with this, with the gastric ulcer and the gastritis?
If they don't have a clear case of epigastric discomfort or something, you can't say that it is related to it. And that's a totally different condition. It's called motion sickness. Okay. That is something different. It takes a different system. It's just like when you were young and you just want to spin around and you stand and you're feeling also dizzy and all that. That's a different system. Your vestibular system in the ear and all that, balancing and all that, and sometimes it can lead to dizziness and vomiting. That is motion sickness. It's totally different. Okay. All right. So can you see the screen? I've projected a new screen.
Yeah.
Yes, sir.
If you follow the cursor, we all know, maybe I should have shown you a normal X-ray, but yeah. Anyways, let's look at this one here, and afterwards we'll see a classic one. You can see that when you look at these two lines.
Sir, please, we can hardly hear you. It seems your voice is a little.
The mic has gone down again. Is it better?
Yes, it's okay now, sir.
Yes, please.
All right, great. So if you take a look at these lungs here, you can see, looking at the right, you can see that the darker aspects, which means there's air in there, which means it's fine. Look at the left. Apart from the dark aspects, look down there on the left. You can see some white line. Can you see it? Some white line, like a rim. Can you see that? Great. You don't find those things on a normal chest X-ray. Once you find that white, like we call it crescenteric, or like a moon, crescent shape over there, then it tells you that the patient has perforated maybe the stomach or the bowel and has gas under the diaphragm. So this is what we call gas under the diaphragm. Okay. And you can see the same thing here as well. This is even clear. On both sides, there's gas under the diaphragm. So you just follow my cursor, you can see it, gas under the diaphragm. So usually you request for a chest X-ray when you are thinking the patient has perforated. If you are thinking the patient has obstructed, then you request for an abdominal X-ray, erect and supine. Surgery will teach you, so I'll go into that. Imaging will also teach you. But once you are thinking about perforation of the stomach or the intestine, you have no business requesting an abdominal X-ray, unless there's also an intestinal obstruction, but you always have to request for a chest X-ray. Okay, so don't ever make that mistake. Great. let me go back to the lecture. So let's finish up. So management is just like we talked about, lifestyle change. You stop, NSAIDs, you avoid it if, you have issues with gastritis, because gastritis can lead to peptic ulcer. Basically, you stop the intake of alcohol. As I said, you stop smoking. It's good to try and lose some weight, okay, especially if you are dealing with duodenal ulcer and you're eating every time. Stress management is also very important. The management is just similar to what we said in the eradication of H. pylori. You're either doing a triple therapy, which we've already talked about, or you're doing a quadruple therapy. Most common triple therapies you find, they do a PPI, clarithromycin, and amoxicillin, most common. I usually would want to do a PPI specifically. I want to hit hard, so I'll give a good PPI like Nexium, and I do clarithromycin, then I'll do augmenting for the patient. If that doesn't work, you are doing a quadruple therapy for the patient. Also, as I said, there's something called sequential therapy. When you read, you find different combinations for triple therapy and quadruple therapy. Okay, so try and read through and get what you are more comfortable with. You can see ones with rabeprazole, pantoprazole, all those things. Try and read around, but this tends to be the common one that we do in our setting. Okay, so basically, if the cause is due to NSAIDs, then you don't need your triple therapy or quadruple therapy. You just need to put the patient on a proton pump inhibitor or H2 receptor blocker for about 4 to 6 weeks, as I said. Then you'd want to see the patient and review the pain in the epigastric region and all that. There's also a role of surgery in management. If it's persistent and you've tried, it's still there, then as I said, because the vagus nerve is what induces the whole stomach to make the HCl and all that, is good. Sometimes you can do what we call a partial vagotomy. So you go and then you cut some of the vagus nerve. Sometimes people do total vagotomy where they cut the nerve supply of the vagus to the stomach, and so they don't make any hydrochloric acid at all. Of course, that will also come with complications and whatnot. So because once you go ahead and you do that, the stomach won't be moving easily. So once you go and do a vagotomy, you have to find a way to join the stomach to the duodenum so that food will move directly from the stomach to the duodenum. Okay. Yeah. If it's that bad and it's ulcerated and all that, you do a surgery, you can cut that part of the stomach off, what we call a partial gastrectomy. Okay. Sometimes if you go and it's inflamed and it's gone beyond and it's perforated, then you have to do a gastrectomy or a duodenectomy and then rejoin. Okay. So that's a surgery. So surgery will take you through Barrett 1 and Barrett 2 surgeries for stomach and then the duodenum. So that's different. But I added it because there's a rule for surgery. Either you are going to clip the nerves or you are going to cut part of the stomach or the duodenum. Okay. So time is fast spent. Let me quickly take your questions and then we bring this evening session to a close. Then we plan for a weekend lecture. So I'll take about 2 to 3 questions if there are any, and then we can close.
I have a question.
Yes, please.
Sir, I realize that most of the investigations are based on antibody test. Does that mean the antibody one is not a reliable test?
Okay, so you need to understand the basis of antibody and antigen.
Hello.
Yes, hi. Can you hear me?
Hello.
I can hear you. I can hear you. I don't know if the rest of the class can hear me.
All
right, great. Okay, so.
Hear you now.
Okay. So we need to understand the basis of antibody and antigen test. If you are doing an antibody test doesn't classically tell you that the organism is present. Antibody test can tell you that either the organism is present or the organism has been present here before. I don't know if you get me. If you do antibody test, you can just like an infection which you get and then it will lead to production of antibodies and later you will recover. You can go ahead and do an antibody test. Antibody test will pick the antibodies, but that doesn't mean the infection or the organism is still present. The antibody is what your body makes. So the antibody is not a classic diagnostic test for picking the presence of organisms. Do you understand? The antibody, you make the antibody. So you can be infected by an organism, you make antibodies, get rid of the organism, and the antibodies will stay. If we test your antibody and you have the antibody, it doesn't mean that the organism is still there. However, the antigen is what the organism is making. So if you want to find the presence of the organism, why wouldn't you do an antigen test instead? You do the antigen test. And that's the reason why we do antigen tests, to identify the presence of the organism. The antibody would tell us, the antibody can sometimes tell us, or sometimes you can have an organism there, you still make antibodies. But it's to tell us if your body has developed some sort of protection to the organism present. However, the antigen would tell us if the organism is present or not. Are you okay? Hello, class. Are we okay with that?
Yes, sir.
Yes, sir.
Great, great. Any other questions, please?
Hello.
Yes, hi.
Yeah, sir. I discovered that despite like you do the H. pylori and the person is negative, and it happened that the cause is by through insect. Yet during the treatment, I saw the antibiotics still given.
Okay.
Yeah, I don't know why.
It's a wrong practice. Okay, it's a wrong practice. It's just like what we do when sometimes we see a patient who has fever, chills, headaches. We do BF for MPs and it's negative, and we still go ahead and treat malaria. Once we do that, what it means is we don't have faith in our practice. We don't have faith in our lab. Okay. So even though malaria test, especially not just audit, BF is negative, then we'll say, well, let's go ahead and then we treat. In some cases, sometimes we are managing some cases, it's not bad. It's just worth putting anti-malaria. And maybe you have a patient, sickle cell patient with high temperatures, you are managing with antibiotics. It's not bad to throw some IV artesunate in for 24 hours there because it would help the patient's recovery and all that, because we have a lot of mosquitoes in our environment and whatnot. But if you are supposed to practice what we call evidence-based medicine, and you want to be objective but not subjective, if you don't find H. pylori, you don't treat H. pylori. You know why? Because you don't find H. pylori, you go ahead and give antibiotics. Your patient becomes resistant to the antibiotics. The next time your patient comes and then H. pylori is positive, your first line won't work because of antibiotic resistance. So it's not a right practice. Okay.
Okay.
All right.
Thank you.
You're welcome.
Hello, Doc.
Yes.
Please, I want to clarify certain things for me in the management.
Yes.
In relation to stress management and then weight loss. Please, can you elaborate how this will help to use this problem? Thank you so much.
Okay. So it's a good question. Stress, as we talked about, is one of the etiological factors of inflammation of your stomach or your duodenum. Okay. Sometimes even when you get some severe medical conditions or even burns, you can develop ulcers in your GI tract, so we call Kerlin ulcers. So stress has been proven to be one of the main causes of you developing ulcer, because it how should I even put it? When you look at the physiological defense mechanisms that we talked about, your misoprostol and all that, excessive stress basically has an effect on your homeostasis, and it can affect your physiological defense mechanism, and that will predispose you to developing some form of gastritis or a PUD. Okay, so if you are managing your stress well, you are well relaxed and all that, then you are protected in that aspect. Okay, in terms of keeping a healthy weight, once, remember we said that when you are dealing with duodenal ulcer, the eating and whatnot comes in, because you want to quench the hunger, because once you are hungry, it gets painful. You end up eating, and usually your eating will be unhealthy. So you have a patient who started with a duodenal ulcer, and now because of unhealthy eating habits, this patient will have hyperlipidemia, and that will also cause other things, hypertension and diabetes. And that's why it's good to keep a healthy weight, because you don't want to increase your other you don't want to increase the predilection for other comorbid conditions. Are you okay?
All right. Yes, I'm okay. Okay.
So in the course of the week, we'll discuss if we'll put in on Friday, Saturday, or Sunday. In the meantime, one page so I can share the link easily, and then you can also put your questions on that page pertaining to the topic. Like for instance, the what we've discussed, see a case on appendix, and you always want to share or put it on the page. You can always discuss, and then it makes things lively and it helps everyone as well. Have a blessed evening, and we will meet again within the week. Good night.
Thank you, sir. Thank you.
Welcome.
I could even, I can't hear anything.